care last week. If you don't mind, I will start today. I've got 4 cases I can share. Can you hear me okay?
Yes.
All right, let me turn up my volume there. Okay. Okay. So this first case was shared to me by my colleague Mark Schiebler. This is a patient who is being evaluated for treatment for hepatocellular carcinoma, and this was all we had was this outside chest CT. I don't have any other imaging studies, but it's biopsy-proven HCC with hepatic vein involvement. And this CT scan is a non-contrast. I'm not sure what they did. I mean, that's what they did on the outside. So we can see there's the distended hepatic veins in the upper abdomen. But what I'll draw your attention to is the IVC and the right atrium. And you can see there's a lot of noise and artifact on this scan. But if you look, there's a low attenuation filling defect. And we see mixing artifacts all the time, but this is a non-contrast. And I think if you're paying enough attention, you'll pick up that there's something there. And then if we go look at the lungs, we also see there's some expansion of these right lower lobe vessels. And right there, it's also, I'm just going to change the window a little bit. We see low attenuation. I suspect there's some in here as well. The coronal is a little less noisy. So hopefully I can convince you there is a filling defect in the pulmonary artery. So I don't have tissue confirmation, but I think given the confirmed findings in the abdomen, I think this is extension of the tumor into the right atrium with probable tumor emboli in the lungs here. I think the patient had renal problems, so we suggested an MRI to evaluate this if it's going to change what they do. But just a reminder, you can see clot and tumor on a non-contrast. There are reports of PEs, usually hyperdense, but in this case it's hypodense relative to blood pool.
Right.
And an MR might be helpful in distinguishing bland thrombus from tumor thrombus. There's even what looks like a little infarct right here in the right lower lobe.
Yes.
Okay, that's the first case. This is a kind of an interesting case I came across with some old imaging. So this is a middle-aged man who was diagnosed with HIV about 15 or 13 so years ago. And he, at the time, lived in Arizona and had a cavitary pneumonia. And so didn't respond to typical treatment. So he eventually got a CT scan. And you can see there's this kind of ugly cavity here in the posterior basal right lower lobe. There's a little bit of fluid in it, but not a lot. But it's got pretty dense margins. And then you'll notice there's just a ton of nodules around it. Some are cavitary, but very discrete nodules, some little Cheerios there in both lungs. Some are super tiny, some are bigger. So this is, given where he was, this is a great look for Coccidiomycosis, which this was confirmed to be. What I thought was interesting, so he got treated with itraconazole standard therapy. So this is him 16 months later. And important point, I know, Howard, you have a lot more experience with Cocci than I do, but we've seen over the years, I've seen enough of it here with our snowbirds and just traveling patients. The cavity you can see collapsed down quite a bit. There's a little calcification in it. There's a little bit of bronchiectasis, but you'll notice these nodules persisted. Although there are fewer of them and some of the cavitary ones collapsed down a little bit. So even with full treatment, this didn't go away completely. And that's not uncommon with Cocci. Sometimes especially the cavitary lesions will persist and never clear up despite treatment, and you can't recover any organisms. Now this may be confounded by his HIV, which he did. At the time, I think he had detectable viral load, and his CD4 count was lower. And as David has mentioned, that's one of the risk factors for disseminated Cocci. As far as I know, it was only in his chest. But this is the most recent imaging he has. He's scheduled for some newer imaging here now that he is relocated. But an interesting case. And just to remember with Cocci, just because you have residual nodules does not mean you necessarily have active disease. So I'll be curious to see what he looks like now. But I suspect that a lot of these nodules are going to hang around.
Interesting. Yeah.
All right, this is a really cool case that I came across. So it's a great case for a student or a junior resident. Just starting with the radiograph, and you'll notice on first observation there's a striking asymmetry between the left and right lung. The right lung looks pretty normal. The left lung is small, but it's also hyperlucent, and you'll notice there's some calcifications here. So you can talk about a differential for a small hyperlucent lung. You could have something congenital, you could have had a resection, could be an obstructing lesion, but usually with those you often, if especially like fibrosing mediastinitis or mass, you often see septal lines and pleural effusions from the lymphatic or venous obstruction. But there's also these calcified nodules here. So in this case, we might entertain like an old infection. Here's the lateral view, and you can see if I magnify it a little bit. We don't see much around the hyla. It's maybe a little bit more tissue here than usual, but with the distortion, hard to tell, but just those calcified nodules. I found a CT from 20 years ago that done on I think was it a 16 slice scanner, so we have some pretty thick cuts, but you'll notice there are some calcified lymph nodes around the left main bronchus. And then more importantly, I'll make it bigger, you'll see there's narrowing of the left main bronchus.
Mm.
And then if we look at the left lung on the lung windows, you'll see there's the asymmetry. So we see hyperlucent left lung, relative decreased number of vessels. All the lobes are there, they're just smaller. Not a big difference in vessel size, but and I think it's enough, particularly in the periphery, they're just a little bit smaller. So this is a nice example of whole lung air trapping. I wish I had expiratory images, but we don't know what they show, related to bronchostenosis. And the cause actually is tuberculosis. He has a documented history of TB many years ago. And we see a lot of calcified nodules, lymph nodes, but I've seen only a handful of cases of airway TB, and this is an example. This is just they did some thin cuts, but they had to do step and shoot for them, so we don't see the full volume, but you can see that narrowing. But there's also some thickening of the wall. So this is long-standing bronchostenosis from TB, but it's a great teaching case for physiology and observing differences in lung attenuation, caliber, vessel size, and volume. And
Yeah,
then
very good.
this last case is kind of crazy, and I'm not 100% sure what's going on, but I have a good thought. So this patient, I gotta find the oldest imaging. So this patient has a long smoking history and had a head and neck cancer. And at the time of staging of that, this, and you can see has this chronic cavity in the right upper lobe, had, we gotta actually go to PET CT first. Yeah, so on the staging PET CT, there was a nodule identified in the right upper lobe right here. So there were no previous chest CTs at the time, and this was FDG Avid. I can probably fuse them on the screen here. Yeah, you can see it was, I don't have the right scale, but you can see it was FDG Avid, and there was an Avid N1 or hilar lymph node. So this was sampled, the hilar lymph node was sampled, and this was non-small cell lung carcinoma. So two primary cancers. Close that out and switch back to this chest CT. So the patient was treated with definitive chemoradiation to the right lung, radiation because of the tumor and lymph node, but also chemo because the lymph node involvement, was not a surgical candidate. And so got radiation to the mediastinum, right hilum, and this upper lobe lesion. And over time, I'm going to show you how this cavity has changed. This very interesting paraseptal emphysema as well, but cavity had been predated the cancer diagnosis. So this was at so treatment was about 2 months, completed about 2 months after the PET CT. This scan was obtained about 6 months after radiation. And we can see the nodule down in that area is harder to see. There's some soft tissue thickening. So that was 6 months after treatment. This is 3 months later. And what's happened, we've seen a change in the cavity. The cavity's gotten bigger. There's now a fluid level in it. And what's really interesting is what I want to show is look at the wall of the cavity. It's got this very fine kind of brawn-like, sort of nodular, but these very fine nodules along the wall of it. And there's airways communicating with this thing. And then we've seen with the radiation, there's contraction of that radiation injury in this wall. So we kind of watched it for a while. They did another CT scan 3 months after the one I just showed. I'll blow it up to show that. And what's happening with this cavity is we're starting to see more of this kind of wall abnormality, very fine. There more volume loss in that right lung, so as the radiation injuries evolve. But the one that was the most interesting was the most recent scan. And at this point, there's still this big cavity. But what was interesting is right here, there's a funny abnormality in this fluid level. So if we switch over to the lung windows, we see what looks like heterogeneous tissue floating in the fluid there. And what I think has happened, if we look at the lung windows again, is you'll notice the margins of this are less, they're still nodular, but they don't have that fine appearance. I think the lining or some of the lining of this cavity has sloughed and has fallen into the cavity and is just hanging out there. So if I go back to the comparison scan, I think this material here all sloughed and is necrotic lung. I don't know if it's called a sequestrum or not, and probably due to a combination of just devitalized tissue complicated by that definitive radiation treatment that covered the cancer field, but also the hilum. So it wasn't your typical SBRT pattern for I don't have the treatment plan, but it wasn't your typical target the nodule. I guess the alternative is this is a low-grade chronic infection that has also led to sloughing, but I would have expected the patient to be sicker, have more symptoms related to that. So it may be chronically low-grade infection, but I don't think I've ever seen sort of sloughing like this from anything.
Wow.
So
that's fascinating.
It is fascinating, and it's purely a conjecture of what's going on. But the fact it's been doing this for over a year, we're pretty confident. I mean, if this were tumor at this point, it should have declared itself, getting more nodular and more nodular. And the fact the cavity the cavity wasn't part of the cancer, and the cavity predated the cancer, I think makes us all confident that this is just chronic ischemic injury and necrosis. And I'll be interested to see what happens with it over time. But I do think this is a pretty good example of just sloughed lung hanging out in there, and hopefully it'll just resorb. Okay, well, those are my bizarre cases of the week.
Excellent.
Let's stop doing that. All right, see David is on, and we've got Peter. So who would like to go next?
I can go next. Have a couple.
All right, Howard, go.
All right, you're definitely going to like this case. So here is a patient that has a PICC. Then I was presented with this to read. And the order was associated with exactly what you see. It said, evaluate PICC, place patient in the lateral decubitus position, left side down, and you can see the patient's arm is abducted. So I thought, that is curious. So I said, okay, I can see the PICC, and perhaps not unexpectedly, given the change in the effective length of that vein and vascular structures with the patient in that position with the arm up, the catheter tip moves down because it's fixed at the arm. And yes, indeed, its tip is now located in the lower right atrium. Okay, so check this out. The patient had experienced palpitations, had relayed that she experienced funny beats when she was on her left side since the PICC was placed. And they actually determined there were runs of PVCs. So time to look for reports, and indeed, it wasn't too long before I found reports like this. And they describe similar situations where when the patient is in a decubitus position, either left or right, depending on the location, that they have PVCs. So it's a thing. And you can find case reports. And then typically they basically just remove or withdraw the catheter, either take it out completely or just remove it, pull it back to see whether that takes care of the situation. So that is really interesting. So they did do that. So they pulled it back that much. And I presume they had her on her left side to see whether she experienced any of these beats or became symptomatic, and she didn't. It's the first one I've encountered. Isn't that cool?
That is very cool. And your point about the PICC moving is important because when reporting these, you have to, if you know, they don't advance PICCs. I mean, it's not supposed to advance, and they're so always looking at where the arms are, because sometimes the patient puts them out to the side for positioning, and then it can make it look like the PICC went down. What I also find interesting is they typically park hemodialysis catheters in the right atrium, but that doesn't seem to cause PVCs. And what I was told by, I think, was it one of the interventional radiologists years ago, is that because the dialysis catheters are much stiffer, they tend to just stay in intraluminal, not float around, whereas the PICC at body temperature is pretty floppy. And so it can, as the heart's beating, it can flop around and sort of so-called tickle the atrial wall, whereas the dialysis catheters tend to stay put.
Yeah, really interesting.
That's nice.
That's one I've encountered. Yeah, because I was perplexed when I was presented with that to read. I thought, what's going on? And then I obviously looked in the medical record, and the physician, pretty attentive, called a little bit after and said, hey, yeah, this is the scoop. So there you have it. And I think they took it out subsequently because I think it was put in for some, and I'm not sure what temporary reason, in the context of some GI issue stuff. So there you have that one. It's nice. Okay, here is a nice case too. Here's a patient that I'm going to bring up the previous one, no, the follow-up for comparison. So here we have 15 and 16. A diagnosis of lung edema was made on the basis of that. The patient was intubated, but was also treated with diuretics. So at this time, by virtue of a history of CHF, a diagnosis of lung edema was made, hydrostatic lung edema from left atrial hypertension. And certainly the rapidity of the resolution of those opacities is quite consistent with resolution of lung water. Now, she did have a CTPA on the 15th, the day before, the time of that. And see if you buy this. When I look at the appearance and the distribution of the lung water in the anterior lungs, I think I'm seeing the so-called intralobular gradient, where in relation to some pulmonary lobules, the water is accumulating with the patient recumbent in the more dependent alveoli within some of the pulmonary lobules. Now, Jeff showed a case just like this, I think a couple of weeks ago, and it was reported initially, or at least one report in the context of re-expansion lung edema. But if you buy this, this is a case in, well, more ordinary lung edema. What do you think?
I agree, and I think Travis earlier had shown a case and shared a paper where it was described as like
right.
the karst, K-A-R-S-T,
mountain.
Yeah, mountains, and I think it was Chinese art.
Yeah.
Yeah.
Yep, exactly.
It's interesting.
So
why do you think the edema is primarily in the anterior lungs as opposed to the
I don't know. I don't know. That is interesting. I mean, this pleural fluid. I don't know why it is. And while we have quite a bit of alveoli edema and almost no interstitial edema, which is also a little perplexing for ordinary everyday hydrostatic lung edema. So I don't know the answer to that.
Does the patient have regurgitation of any kind?
Not that I know of. No, I don't think so. Mitral regurg? No, I don't think so. So certainly curious.
Yeah, no, that's a nice example of that appearance.
Yeah. Yeah, so the so-called intralobular gradient of water. And yeah, there's a Chinese picture of karst mountains that the authors of that article included in their article. It's kind of artistic license, but they sort of analogize that to the appearance of the karst mountains in that painting of the karst mountains.
It's good that you're showing these this case, because I'm seeing a lot of. I think it's important to be able to make the distinction, because now a lot of patients are showing up with lots of ground glass, and like the junior residents and trainees. First instinct when they see diffuse ground glass is to question COVID. So we've seen a few patients actually that have COVID positive tests. They come in with COVID positive, but they have appearance like this, and it looks much more like edema than COVID. And then I checked the chart, and they got loaded with fluids in the ED, and they went into pulmonary edema, and they just happened to have COVID tests. I've been seeing that quite a bit the last few weeks. That's a good skill to have, to be able to see.
Yeah. This is one that we all kind of know about, but we tend not to see a case of it. So here is a person with SLE. So this is from 2019. At the time that he was symptomatic, we go forward here to, and I don't have a chest radiograph, I just noticed. So let's compare that with this one. So you'll have to imagine what a chest radiograph is going to look like. And the striking finding is the underinflated lower lungs. And within those areas are opacities consistent with enhancing atelectatic lung. So multiple foci of basilar, both sides, atelectasis. And he has restriction on pulmonary function testing, and the rest of the lungs otherwise look okay. So by virtue of that and the change, and also findings of restriction, it's been decided that this is probably an example of the so-called shrinking lung syndrome of SLE. And I think I buy it. I mean, it's a thing. He's had this for quite some time. And here's some clinical information. He's been treated for that for some time and been attributed to that. So in the absence of an alternative explanation, this is probably exactly that entity. I still don't quite understand exactly what that is. Is it a form of myopathy that affects respiratory muscle and hemidiaphragm function? I think that's one of the theories. But would anyone think that that's an implausible explanation, or at least a reasonable one?
I think it's reasonable.
Given these findings.
Mm-hmm.
There is some pleural fluid as well, but the lungs are very underexpanded, and I think they've been that way for some time. Well, not for some time, but more recently. Let's see, this is March of 2020. Foci of subsegmental atelectasis, perhaps to a lesser degree at that time as well. So yeah, perhaps this is a case of exactly that. Oh, we can look at the topogram here. So he's had it since 2020, not just recently. Yeah, I think that's plausible.
Yeah, I agree.
Good. Let's see, I'll show you one more. Okay, this is a patient with a history of a hematologic disorder. I'll check it out in a second. Here is the radiograph that I interpreted as a bedside radiograph in December. And I noticed on that, or at least questioned the presence of ill-defined opacity in the upper portion of the lung. Now that's a bit hard because the clavicle's there and the ribs are there, but the presence of it was confirmed by non-bedside radiography. So we see that there, and hard to see the opacity, but certainly there. So that's on the 14th, and a CT was done on the same day. So here it is. In an immunocompromised patient or potentially immunocompromised patient, certainly all of us would quite readily be concerned about an opportunistic infection, particularly of fungal or Nocardia etiology for this opacity. It's a bit of a ground glass halo around it. Interestingly, more inferiorly, presumably this is all an inflammatory process with lung water and peribronchial fluid cuffs, but an intense inflammatory reaction, presumably. He don't know if he actually had symptoms, but indeed he was found to have cerebral and cerebellar lesions. A CT-guided biopsy of that was done here. And any guesses? Not that we can guess what it is, but
Around here, I'd say blasto.
yep, I know what David's going to say.
Nocardia, yep.
Nocardia nova. Nocardia
Like a fungus.
nova. Good from that. Yeah.
That's been my experience, Howard. Nocardia always seems to look like a fungus.
Yeah.
The other thing that Nocardia likes is to go to the upper lungs. So that was my first consideration here, given how high this thing was. So Nocardia likes the lung apices. And fungi don't like that location as much.
Have you guys seen this type of Nocardia before? I've never heard of it.
Yes.
There's so many of these species now. Now, we used to talk about asteroides, but I think asteroides is now being broken up into like 10 other subspecies, however they classify them, one of which is nova.
Okay.
I see that from our lab too.
But there's nothing different about this. I mean, this one would behave just the same as the other ones, the garden variety.
Yeah.
They're all opportunistic.
Yeah.
Yeah. Yeah, exactly. All right, Jeff, I'll stop there for now.
All right, great cases, thank you. All righty, Peter or David?
I've got a couple.
All right.
I hope people can see a chest radiograph here. There's a slightly strange look to the lower trachea here, just above the carina. You can see it takes a little swing to the left. Funny looking mediastinum a little bit through here. And lateral view, we see the airway coming down. It looks as if there could be something leaning on the airway from behind, right in this location. There's some implants going on up here. This is a case that Howard helped me with, trying to get images to display properly. And here is a CT scan. We don't have a CT scan of the chest. And this condition was not actually diagnosed because people's attention was really focused on the spine. But nice thing about spine CTs is that they include some more interesting parts of the body. And so we can see that there is a lesion around here at the carina, this big smooth tube here, which heads out into the left lung and becomes the left pulmonary artery. And it originates from the right pulmonary artery. So this is pulmonary sling. It's wrapped around the lower trachea, and that's why the trachea is displaced and a little bit narrowed just above the carina. So incidental finding here of a pulmonary sling on radiographs and then a spine CT.
David, are there any airway anomalies that you can make out?
Besides that tracheal narrowing, it looks like a right upper lobe bronchus ordinaire.
Okay. No bridging bronchus.
No.
So tracheal narrowing, do you think, it doesn't look like complete rings, does it? No.
No.
So it's probably just isolated.
Yeah. Okay, so sling. And then I'd like to show you this port catheter here. So the requisition mentioned something about the question of the port being flipped, and you can see that this port, we're not really seeing it face on. It looks as if it's tilted to the side, and let me magnify it, and you can see that there are letters CT written on there. Okay, and so here they are. This catheter is slightly tilted, and here is the same catheter now at a different time, and you can see that the CT is now a mirror image. So you read CT from right to left rather than left to right, and it's that way all the way around here. It's not just a question of this thing being upside down, but this port is actually flipped in the pocket, and the back part of the port is out, which is a hard surface that cannot be injected. So the patient was aware that the port seemed loose and seemed to sort of flip around. And this, at this point, we got it at the time when it was flipped. In that previous radiograph I showed you, it was sort of situs ambiguous. It was kind of on its side. And this is the time of when it was actually placed. And you can see that we have the orthogonal left to right reading of the letter CT, so it's not a mirror image. So this is the point when they placed it. Now I read the note of the IR person who placed this catheter, and they create a pocket and they put the thing, they feed they tunnel the tube from there, and then they plug it into the port, and then they just close the pocket on top of that. They don't actually fix it to tissues, so it's in the pocket. It's supposed to be held in position, I guess, just by the overlying and underlying layers of tissue. There's no fixation to keep it from flipping. It's important to recognize this. I always check to make sure that the letters read properly, CT, and it's not a mirror image, right to left reading of those letters. Sometimes the CT is upside down, but then if you just invert the radiograph, it should not be a mirror image. So if it's a mirror image, you should let them know so they don't try to inject the wrong side of the port and get extravasation. Not cool. And this is just a reversed image of that port placement radiograph. So very alert to catheter port malfunctions. This case was the next one that I encountered the next morning, and on that morning, and I was alarmed here that this needle seems to be heading off the circle. So this implies to me that the needle has not entered the port. So the port is defined by this circle. This tip should be within the circle. Now it's possible to get parallax error if because the needle could be on its way to the port. It could be hovering over the port. If you had a lordotic projection, you could project the needle tip off the circle, which is on the back behind the soft part of the port, the injectable part of the port. But this, I could not explain this as a geometric thing. It doesn't look as if it's a lordotic projection that could result in a parallax error looking like a port problem. So despite my, reporting that this could be external from the port, not having entered the port, they went ahead and used the catheter. They said they got good blood return. They had easy injection, and so the port seems to be functioning. I don't know whether the needle adjusted somewhat between the radiograph and the time that they used it, or what happened, or whether this is somehow a misreading of this geometry. But you should always be very alert to making sure that the needle is not outside the port before they inject, extravasate, and then cause tissue necrosis. So does anybody have an explanation that would make this not alarming?
No, it does look off. I mean, everything is
Agreed.
straight on, as I can tell too. Oh,
Okay.
curious.
Well, it's either an overcall or there was some subsequent adjustment.
Maybe they just adjusted it and just pulled it back in like a half a centimeter and pushed it back in again, and it was fine. And
Yeah.
didn't tell you something like that. Maybe.
Yeah. Okay. So, I think I will continue then to raise alarm when I see this sort of thing. Okay, guys. Thank you.
All righty. Peter, you ready?
Yeah. So this one's good for students and junior residents. It's just a patient mid-30s, shortness of breath, cough, productive cough symptoms, weakness, weight loss. So right upper lobe, central lobular nodules, cavitation. Ended up, ID was consulted. They did a full workup. HIV was negative, but the sputum cultures are positive for tuberculosis. Nice.
Yeah, really. So we have at least two dominant foci of cavitation. Wow.
Yeah, I mean, this one, there's a smaller one, a little bit more inferiorly right here, and then one in the lower lobe also.
Gee. And the bronchioles around them are just full.
Yes, yeah. And not much in the way of ground glass or consolidation. It seems like. Yep.
Yeah, very dramatic.
Do another infection. So this gentleman is in his mid-60s, and he's on steroids for an inflammatory arthropathy. So he has these consolidations. Any guesses what the bug was?
Let's see, we have cavitation, multifocal, rounded cavities. Oh, could be something bad. It could be something bad. Could even be
somewhat
immunocompromised. Mucor even.
Yeah, ugly fungus or nocardia.
Yeah, so ended up being a Cryptococcus. So this was biopsied. And they saw budding yeast, and then also a culture grew Cryptococcus.
Nice.
Oh.
I guess most labs don't speciate it to Gaddii or neoformans, but because they look pretty almost identical. But
I think it was neoformans. So Gaddii looks identical in general. So.
Yeah. I think it takes like special, either molecular or special testing to distinguish them. They're all identical.
So I was talking with one of my colleagues about, because I remember reading in one of the lung imaging infection books by Dr. Mueller about these. And what I recall seeing is that in the section on Cryptococcus, they're saying that the patients that are immunocompromised tend to have more patchy and ground glass, ill-defined opacities than immunocompetent patients that are more nodular with Cryptococcus. What do you guys, is just kind of non-specific in general, or what do you guys usually see with Cryptococcus?
I usually see large nodules and masses it's rare to get, it does occur in non-immunocompromised patients, but it's uncommon. I don't see it. But when I see like that one right there in the right lower lobe, when I see big round nodules in an immunocompromised patient, crypto is high on my list. Because with like other endemic fungi, like the histoblasto, it's more miliary disease, or blasto can be like big masses, and then cocci same way. Now nocardia could look like this too, also big nodules, consolidation, but I've never seen it not have big nodules.
In other words, it doesn't like just like ground glass, like pulmonary hemorrhage, like with the angioinvasive.
Yeah, I've not
disease.
seen that. It doesn't mean
this,
but
yeah, I mean, this looks like there's some chronicity here also with the scarring and volume loss. But I don't know to what extent this gentleman would be. I mean, it's technically he's immunocompromised, but he was just on steroids, so he wasn't. I mean, he wasn't like a transplant neutropenic category of immunocompromised. But he definitely is to some degree.
Yeah.
Well,
The area of
steroids
necrotizing.
are all it takes. Steroids
Right.
is the perfect immune compromise for crypto and for nocardia.
Uh-huh.
As a matter of fact, we've seen both organisms in people who are on, say, dexamethasone for brain swelling because they have brain metastasis or some other thing. And so, crypto loves that.
Yeah.
So now crypto is famous for, you're asking about patterns of crypto. You can
Right.
have a slow-growing, very discrete lung nodule that looks like a slow-growing tumor that people follow for months. And that's one pattern you can see in an immune-competent person, a very slow-growing, big nodule that looks more like tumor than it does like infection. So that's one of the patterns. When we did a study of crypto when I was back in my Duke days, and about 50% of the people were immune compromised, but 50% were not. And they included people like a telephone linesman who was out in the field a lot, but is a healthy guy in his 30s and stuff like that. So you can get it as an immune compromised person. In that population, every population is skewed. Only 50% of the people had an identifiable immune compromise. And one more thing about distribution, crypto likes the lower lobes. So I've seen a number of cases where you've had a couple of nodules, say in the superior segment or farther down in the lower lobe. Aspergillus seems to like mid lungs. Mucor likes mid lungs and can move toward the apices. It's sometimes at the periphery. Aspergillus tends not to be at the periphery, but that's a fairly common pattern with mucor to be right out against the edge of the lung.
Mm-hmm. Yeah, I only had one other case of crypto saved in I know you guys have showed quite a few, but I had one other case of crypto, and it was a lower lobe, and it was again kind of round nodular shape. So makes sense. Okay. This is just a quick one. This gentleman is in his mid 50s, and he already had a aortic valve replaced. He had dental cleaning in December, and for several weeks after that, he was short of breath, feeling sick, just difficulty getting around the house, short of breath. So yeah, here's his valve, and then you can see this the aortic root is markedly abnormal. So basically the valve prosthesis is dehisced here, and then you have this big abscess, aortic root abscess, which fills in with contrast, and he has a large perivalvular leak. So he had positive blood cultures for a strep. He had his whole he had a reduced sternotomy, and he had his aortic root replaced.
That's a large area.
That's very large.
I always think that for surgeons, that's a nightmare, because if they didn't understand what you're going to have to do to fix that, what you might encounter. Does it involve the aortomitral curtain? Does it go into other structures?
Yeah.
That's not good.
Yeah. And one last one is this one. This one was interesting, and I haven't seen something exactly like this. So this guy, well, I'll show the CT and I'll give some history. So here's his imaging. So he is a middle-aged patient in his 40s. He's from Mexico, and he's one of the states in Mexico, Hidalgo, Mexico, where it's a huge mining industry there. And so he spent like 10 to 15 years mining white rock in in Mexico, and he's been having just progressive shortness of breath. He's been on asthma treatments, albuterol, and it hasn't really been helping him. So basically, and then yeah, so the mineral stuff that he has been mining is high content of silica. So this is presumed silicosis. I don't see too much silicosis here, so we'll see what you guys think about it. But essentially, you can see this fibrosis here in his hilum, and then I mean the vessels are abnormal. There's venous congestion, different lobes here. So some of the veins are occluded. Definitely the left upper vein is occluded here on both sides, I think. But the interesting thing is, so with silicosis, I mean, some of this makes sense for silicosis with the fibrosis. I don't see nodules, and I haven't seen a whole lot of these type of varices that have formed here. Looks like they're kind of mimics of AVM. I recently looked at this. Let me pull it up here. Yeah, so this article was published in the recent Journal of Radiographics CT appearance of pulmonary AVMs, and this is by the group in WashU. I haven't had a chance to. I just perused it. I haven't had a chance to read it, but I look forward to reading it. But one of the things they talk about here is the fibrosing mediastinitis and veno-venous collaterals.
Yes.
So I'm assuming that's what's going on. I just haven't seen that with silicosis, but I don't see much silicosis. So
I'm not convinced it's silicosis.
right.
I mean, this is way too odd for silica as well.
The history makes sense, but it's just.
Can you show the upper lobes again? I want to see if there are the perilymphatic nodules. Go all the way to the top. Let's take a look up there first with the lung windows. I mean, there are some nodules there, but
yeah.
So there may be silicosis, but I have not seen. I've seen a fair amount. I know David's probably seen the most. I have not seen a fibrosing mediastinitis phenotype at all, and I wonder if this is a separate process. Those nodes are also very low attenuation, which doesn't typically. Fibrosing mediastinitis from histo is much denser, but I have seen it with sarcoid, and it's been reported with TB, because those lymph nodes at the hilum, which are definitely causing mass effect, look very central low attenuation. That would make me think more TB or some other chronic granulomatous infection, not your typical histo dense calcified, and it's usually unilateral. This is a bilateral process too, which I don't know. I don't buy it for that silicosis causing the vascular stuff. I don't know what David and Howard think, but
yeah, I agree. This is in a sense a florid sclerosing mediastinitis highlightus picture, where it's taken out structures and enclosed them in collagen rather than the usual complicated silica in the lungs. This is quite different from that too. I agree.
So basically, you guys think this is a fibrosing mediastinitis from an infection, and you might have some mild silicosis.
Or sarcoid. So sarcoid or histo. So can we or TB? Can we look at Mr. Spleen, please, for calcifications?
Nope.
Nada.
No, I don't like the lung nodules for histo. I think there is dust disease, because when he showed the upper lobes, there are perilymphatic nodules, but typically nodes with silica, that's silicosis. I buy that, no problem. It's the central and vascular stuff I don't like.
Sarcoid. What do you think about sarcoid?
Yeah, or sarcoid.
Yeah. So, or he's entitled to have more than one disease. So, yes, he's been a minor, but I think he's got sarcoid or an infection on top of that. And I have not seen fibrosing mediastinitis from silica or coal dust.
Yeah, that's his main problem. And unfortunately, it's really severe, and he's taken out a lot of structures, and he's in a world of hurt, unfortunately, relatively speaking.
Yeah, pretty impressive congestion here.
Yeah.
Yeah,
Is
that's
this pulmonary artery? It looks to me as if you
No,
might have.
pulmonary arteries didn't really strike me as it is dilated here a little bit.
And it's got, it looks as if there's a little right heart strain too, maybe.
Yeah, a little bit.
Oh, there's a lot of tissue about vessels and bronchi in the hilar, infrahilar, mediastinal region, all over.
Yeah.
And
The more it looks awful.
I think somebody should sample some of those nodes.
Oof.
yeah, I think that's worthwhile. Those would be easy to get with eBus.
Yeah.
Cool case.
Cool.
Yeah, that's dramatic. Dramatic case. Oof.
Yeah, thanks for the input. That makes sense.
I like those lung lesions, those veno-venous things. I'd not heard of that.
Yeah, yeah, I can send that article. It just got.
David, because if one of the branch veins is occluded, it just blood shunts to a different route if possible. Probably there's these channels that open up because it's with fibrosing mediastinitis, it's such a slow process that the lungs have years to find alternative pathways. We also see transpleural collateral vessels that open up as well.
Yeah.
That pleural sort of looks like almost not quite septal thickening, but there's little. You even see a little bit there. There's this little.
He probably has some of it. Yeah, he probably has some.
So Jeff, you've seen this before then?
I have seen the veno collaterals with central obstruction. Yes.
Cool.
Peter, can you go to the mediastinal window again and follow the left pulmonary artery outward?
It becomes hard to follow actually, just because the density.
Oh, look there, just stop right there. Now go back a little bit. Can you see how that pulmonary artery is almost surrounded by tissue?
Yeah.
Very narrow, irregular by tissue around it.
The superior vein is doesn't really exist anymore.
Whew, yeah.
Well,
Gosh.
that's a fantastic case. Whenever you get a chance to send it out, Peter, I'll comb through it some more too and see what else.
I'll send it, and I can actually send a few other. I had a few other acquisitions that were done at outside priors. I think one of them is not. I'll send all. I don't have them here, but I'll download them and send them to you guys.
But yeah, I think maybe seeing an interventional pulmonologist like David suggested to sample some of those highlights really wise. Yeah. To make sure.
I'll see what they've decided to do. I think pulmonology saw them, but they think their working diagnosis is just silicosis. But I'll check.
No,
it doesn't fit.
The only theoretical question is to what extent they can find narrowed structures and somehow open them up with stents and or other things.
Okay, well,
that's all I have, guys.
All right, great cases, guys. Thank you, and I will talk to everyone next week.
Take care.
All right, thanks everyone.